So good morning once again, everyone. It is such a pleasure to present here today at the Let's Talk Overdose conference. This presentation this morning is titled Exploring the Impact, a Clinical Study on Fentanyl Use in Vulnerable Populations. So before we get started, I always want to do a land acknowledgement. Wherever you are this morning, maybe just take a second either in the chat or just for yourself. Do the same. So we respectfully acknowledge that we are gathered today on the traditional, ancestral, and unceded territories of the Squamish, Musqueam, and Tsleil-Waututh nations. We honor their enduring presence and deep connection to this land. We are grateful for the opportunity to live, work, and learn on these territories. So just for introductions, I'll start and then pass it along to the rest of my team. My name is Vivian, and I am a research track resident in the UBC psychiatry program. And currently, as some of you may have noticed, are chatting this earlier before the presentation on a geriatric rotation at St. Paul's. I'll pass it over to Raha to continue the introductions.
Hi, everyone. It's so nice to be with you all here today. My name is Raha, as Vivian mentioned, and I am the research assistant for this study with the UBC Department of Psychiatry. And I'll pass it over to Martha.
And good morning, everybody. I'm Martha Ignashevsky. I'm an addiction psychiatrist working at Vancouver General Hospital on the Complex Pain and Addiction Service, and I'm also the Senior Medical Director of Substance Use and Concurrent Disorders at BC Children's Hospital. I do have a couple of relevant disclosures for the presentation today, and that is that I am the recipient of a Vancouver Coastal Health Research Institute team grant that actually was used to fund the development of this survey and the study results that we'll be talking about today. And I've also received speaker honoraria for Indivir for educational content that I was able to develop independently from them.
Thanks. So a little bit of background about the BC Fentanyl Cohort Study. This was actually started a few years ago now, funded initially by the VCHRI team grant, which Martha just alluded to. This allowed for the initial phase of data collection at Vancouver General Hospital, which for context for some of you who might not be from Vancouver, it's a tertiary care center in the heart of Vancouver and one of BC's largest hospitals. The study is led by co-PIs, Dr. Michael Krautz and Dr. Martha Ignashevsky. So our presentation today covers the data from our first 220 patients. Now, these were all patients recruited at VGH, but since then, we have now expanded the study further to recruit patients from different sites across Greater Vancouver, with plans to continue that as well. So, for context as well, it is important to first understand drug markets as a dynamic shifting system, which changes based on demand, competition, legislation, and revenue. Now, the major feature of the current drug market shift in North America is towards highly potent synthetic opiates, such as fentanyl and fentanyl analogs. Now, this trend started in the kind of early 2010s, and soon it became almost impossible to find naturally occurring opiates such as heroin in the BC drug market, at least. We also see an important shift towards co-use and comorbid use of fentanyl with other substances such as methamphetamines, as well as benzodiazepines. Now, there are many different ways to show this data, but the overall takeaway is that unregulated drug toxicity deaths in BC is driven by fentanyl and synthetic analogs as the dominant street opiate. And we have been seeing increasing rates of overdose deaths with escalating rates of death annually, despite intentional attention and response to the overdose crisis, which was declared back in 2016 now. And if you break down the numbers, this averages out to about 6 to 7 people losing their lives daily to drug toxicity deaths in BC. Now, drug toxicity is also the new leading cause of death as of 2023 for all subdivided age brackets of individuals from ages 10 all the way up to 59, which is quite incredible if you think about it. Now, this shift in drug markets towards fentanyl and other synthetic analogs has led to profound changes in opiate use patterns and health consequences, and has ultimately resulted in over 42,000 BCEHS calls for overdoses and 2,511 overdose deaths in 2023. This is really necessitating a re-evaluation of substance use disorder care, as well as current practices and policies. Now, in looking at the treatment process behind these staggering numbers, we've noticed a few things. First of all, traditional approaches often fall short in addressing the risks of synthetic opiates, which actually requires a lot of customization across different care settings. For example, Canada faces disparities in OAT coverage and low retention rates, which poses challenges in mitigating harm. In addition to that, detox programs also face high dropout rates and low completion rates, which further highlights the need for comprehensive and adaptive strategies. In addition to that, geographic disparities, stigma, and limited harm reduction tools further compound treatment accessibility issues. And finally, and most recently, Canada has adopted an approach which emphasizes safe injection and safe supply, but its effectiveness warrants evaluation against international models and evidence-based data. So therefore, in addressing the synthetic opiate crisis, requires really a comprehensive strategy that improves access, retention, the effectiveness of treatment models, and to establish continuums of care and multifaceted support for people who use substances. Now, this project has a few key research objectives. So first of all, we really want to document the ever-evolving patterns and routes of administration, especially for patients who use fentanyl specifically. Secondly, we want to analyze risk and protective factors contributing to mortality and survival rates. Thirdly, we wanted to analyze the response and engagement of people who use drugs in the existing system. And lastly, we wanted to obtain feedback about existing healthcare approaches and addiction treatments from service utilizers. Now, the goal of these objectives is really to work to inform future healthcare system developments. Now I'll pass it on to Raha for the next part of the presentation.
Great, thanks, Vivian. Awesome. So now I'm going to speak a bit on the methodology that we used when we were approaching this study. So to talk about the questionnaire and how that was developed, it was developed through expert consensus, and we took on an iterative and developmental process. The survey itself, it prompts a whole slew of different information like demographic info, fentanyl use and history, patients' experiences and opinions related to the system of care and safe supply, their overdose experiences, their risk management and risk awareness with fentanyl use and treatment, questions about their mental health, their physical health, and childhood trauma as well, administered through the Adverse Childhood Experiences Questionnaire. And that is also known as the ACE questionnaire, which I'll talk a bit about later as well. But that asks questions about experienced abuse, neglect, and household dysfunction experienced for the age of 18 years old. So in terms of the recruitment sites that we utilized for this study, as Vivian mentioned, we recruited mainly from Vancouver General Hospital, which is a site where patients are admitted to acute care. So participants for this study were recruited through convenient sampling at the Complex Pain and Addiction Services at VGH. In brief, participants who had an OUD, opioid use disorder diagnosis, and who self-reported street opioid use in the past 6 months were deemed eligible and consented by the CPAS staff. Then they were referred to the research coordinator and myself, who we worked with a team of volunteers to initiate the survey during the course of their hospitalization. The questions themselves were hosted on the Qualtrics software online and provided verbally by one of the research assistants for respondents to respond to. And the duration of the survey really varied based on patient factors, but it averaged 30 to 60 minutes. And at the end, patients received a cash honorarium for their time. And something that I really wanted to highlight as well is how big of a collaborative process this whole project has been. It's really occurred at all different stages, from creating the questionnaire to implementing it. As I mentioned, we also work with a team of 12 wonderful volunteer research assistants and myself at VGH to recruit the participants. And we often work collaboratively a nursing team to check if patients are in a, sorry, it seems like someone's not muted. I'm going to go ahead and ask, thank you so much, Anna. So yeah, the nursing team, we work with them collaboratively to make sure the patients are in a safe space psychologically, temperamentally, to actually complete and participate in the survey. Or if they have any specific needs that we should be aware of with respect to having these kind of discussions with them, because of course it can be quite sensitive. And yeah, it was really important for us to establish clear communication with the care team as well to make sure that the survey and the participation was not interfering in any way with patient care, and navigating how to be most proactive in administering the survey. And finally, of course, collaborating with the patients themselves in getting them to feel comfortable and safe in speaking about things that can be really difficult was a big part of that process, and kind of developing that sense of trust and honoring them was a big part of the process as well. So now to speak on some of our findings. So on this slide, we can see the sociodemographics presented. So we see that the majority of participants in the study have been male, 66%. 58% have been white when it comes to their ethnicity. The mean age is 43 years old. 56% of participants had education level of high school completion and beyond, and 55% of participants are experiencing unstable housing conditions, with 54% being either dissatisfied or very dissatisfied with their housing situation. And 17% of participants have been employed for wages, with the remaining being either unemployed, on disability, or self-employed. And yes, so this slide presents some of our findings related to the concurrent disorders of our patient population. So we see that 77% of participants were diagnosed with mental illness, and 57% had expressed suicidal ideation over the past 6 months. The final point of this slide talks about ACEs, the adverse childhood experiences that I spoke on earlier. But again, this refers to a list of traumatic or adversarial events that people can experience across the lifespan. We know that high rates of ACEs are associated with increased mortality and morbidity across the healthcare sector, but this is especially salient when it comes to mental health. So we saw that our patient population had very high rates of ACEs. For most people, the numbers are between 1 to 2 ACEs across the lifespan, but 70% of our population had between 4 and 10. So that is definitely telling of the level of care that these folks need when it comes to their trauma, delivering trauma-informed experiences or care for them. And perfect, on to the next slide. This slide depicts the fentanyl patterns of use for the participants. So when it comes to participants expressing preferential use of fentanyl, meaning that when they're seeking to use illicit drugs, are they seeking fentanyl preferentially? 40% say yes, 40% say no, they're looking for other substances, and 20% actually state that it's the only thing that's available, which kind of speaks to the drug market and the dynamics there that Vivian alluded to earlier. And the second set of points is on the routes of use, the routes of administration that folks are using to consume fentanyl and consume opioids. We see that 72% of the patient population is smoking, and 19% is both smoking and injecting, with injection and oral administration and snorting being much lower. And we see that given that our patient population is mostly smoking, we compare it to the rates seen by the BC Coroner Service for people who are dying of fentanyl overdose, as we see on the right-hand side of this slide. And we see that these rates are very similar. So this is kind of telling of how there is a perception that smoking is safer than injecting. And from a communicable disease perspective, this might be the case, but from a lens of overdose prevention, we know that smoking is not a form of harm reduction per se. So in discussion with clinicians such as Dr. Martha Gniszewski, who's working in the field, we know that physicians and clinicians and members of the healthcare team have done a really good job in reducing harms associated and sharing the risks of injection and providing tools like safe supply and safe injection sites. So that's definitely a positive. But when it comes to the prevention of, when it comes to the overdose death prevention, smoking is definitely playing a major part in that still. So that's something to consider for sure. And to move on, when it comes to folks thinking of stopping their fentanyl use or even reducing their fentanyl use, we see that a staggering majority of our patients are wanting to. So 84% of folks are thinking of stopping or reducing their use. And 46% are currently in substance use disorder treatment. So when it comes to the discrepancy between people wanting to stop or thinking of reducing it and actually having the means to, we can kind of think back to the way that treatment options and availability of resources might be falling short for people as well. So now to kind of segue into treatment options and the experiences that folks have had, this slide depicts the experiences and then participation in opioid agonist therapy, which is a really common approach to addressing opioid use disorder. So we know that 39% of our participants have tried Suboxone and 37% on methadone, and these are definitely the most popular forms of opioid agonist therapy for participants, with 21% using Cadian, 19% using injectable opioid agonist therapy, and 8% having used Sublocade. So now I will pass it on to Martha to carry on with the presentation.
Thanks, Raha and Vivian. For the purposes of the presentation today, we've also interspersed some of our findings within the available existing evidence-based and previous research that has happened, in part because we are partway through our survey. We haven't completed recruitment. We're still going through the process of data analytics. So we thought it would be interesting and relevant for the audience members to compare some of the findings that we have with existing research. Recognizing that much of the existing research is going to have been emerging as or have taken place as fentanyl and other synthetic opioid analogs were emerging in the drug scene. So we know that pharmacologic treatments for opioid use disorder are essential and life-saving medications, but successful induction of them and long-term retention on them can actually be pretty limited across many settings. The period of induction on opioid agonist therapy is actually the highest risk of mortality in the treatment course, and the first 2 weeks are associated with the greatest risk of discontinuation. What this study from 2021 is showing is that the majority of patients who have engaged with opioid agonist therapy tend to showcase a pattern of engagement and disengagement. So what we're seeing is among 224,000 OAT episodes among 45,000 individuals, which is roughly 5 OAT episodes amongst each individual. Now, that's not specifically true from this finding, but that's what the average would show here. And the uptake of opioid agonist therapy and rates of initiation were a little bit different in our patient population relative to this BC representative demographic, which showed that methadone is preferentially initiated by the majority of patients in about 74% of cases, followed by buprenorphine at about 25%, and then sustained release oral morphine or Cadian in the lowest percentage. Now, our numbers may be a reflection of changes in opioid use disorder management guidelines, which have taken away the language that suggests that certain opioid agonist therapy should be first or second line. Rather, this is now based on a collaborative discussion with the patient and thinking about what best meets their goals. But there's also been across the continuum an increase in uptake of buprenorphine, and especially extended release buprenorphine, due to the awareness that it can reduce overdose. I think what's particularly salient in this slide is that the completion rates of induction are low. So of patients who were initiated on methadone, only about 60% completed the induction, which this study actually defined at a dose of 60 milligrams per day, which in the fentanyl era may arguably be too low. And clinically, we're aiming for doses between 120 to 150 milligrams of methadone in order to stabilize a fentanyl opioid use disorder. For patients on buprenorphine, about 60% completed induction, which is to about a rate of 12 milligrams per day. And similarly, for sustained release oral morphine or Cadian, we see completion of induction rates at about 40%, which the group defined as a Cadian dose of 240 milligrams per day. I bring this up to identify that our current system of care, our model of engaging patients is struggling. We're seeing that less than 60% of opioid agonist treatment episodes are associated with completed induction. That feels very relevant for me, seeing patients in the emergency department, where I may see individuals on a fairly consistent basis when they're really trying to get started, and doses of 40 milligrams of methadone are insufficient to uncouple them from the unregulated drug supply, and they're continuing to engage in these drug-using behaviors. I think what's interesting and also showcases the increased prevalence and use of buprenorphine is that over time, the induction and completion of induction rates for buprenorphine improved and actually started to exceed that of methadone, but methadone continues to hold the best evidence and outperforms other opioid agonist therapy for long-term retention. The caveat there being that that does not seem to be the case for injectable opioid agonist therapy, which does indicate, it does show the best retention and engagement rates in patients. Now, why am I spending so much time talking about opioid agonist therapy? And the cause for that is multifold. We know that opioid agonist therapy is associated with a reduction in all-cause mortality. And so these are troubling rates that we see patients starting medications, dropping off of medications, not getting to effective doses, because adherence is associated with greater retention. There are reductions in unregulated opioid use, which also has downstream reductions in risk of fatal and non-fatal overdose. There's a shift in substance use related behaviors for patients on opioid agonist therapy, and there's a reduction in sex and drug related HIV risk, and just a general uptake of health related behaviors such as HIV and hepatitis C testing, and an across the board reduction in criminal activity. From a health savings perspective, we do see healthcare expenditure savings across the healthcare system. When we think really specifically about the impact for individual patients, we see improvements in quality of life and overall mental health symptomatology. And some of you might be wondering, is this data that was showing that opioid agonist therapy is effective was effective and had such great rates when heroin was the dominant street opioid? But what this group did in 2020 was publish a population-based retrospective cohort study. And this was actually the first study in Canada that showed that opioid agonist therapy continued to be effective at mortality reduction during the current period of fentanyl contaminated drug supply. And so what the group did was they linked several administrative data sets, which looked at medication dispensation, hospital admissions, physician billing records, ambulatory care reports, and deaths across British Columbia, followed all of the OAT recipients from the date of first dispensation or prescription to either administrative loss to follow-up or to death. And what they found was among the 55,000 patients who received opioid agonist therapy through 2018, the all-cause standardized mortality ratio was substantially lower on opioid agonist therapy, 4.6, relative to that off of opioid agonist therapy, 9.7, which showed a 2.1 higher relative risk of death off opioid agonist therapy compared to a 3.4-fold increased risk of death when fentanyl became the dominant opioid supply. So putting that another way, essentially what this group showed was that adherence to opioid agonist therapy and effective dosing was even more protective against overdose in a fentanyl period than it was in heroin. And that really serves to highlight the importance of thinking about what is the experience of patients as they're accessing care, as they're initiating opioid agonist therapy and engaging with the other levels of care, because that's going to determine our ability to engage and retain and provide successful care. And so Raha will continue to talk about some of the findings from treatment experiences.
Great, thanks, Martha. Yeah, so now to talk about other levels of care that Martha was alluding to, we asked patients about their experiences with forms of treatment, including detox, bed-based treatment, and residential treatment, and other forms of treatment like oral naltrexone, Narcotics Anonymous, and therapy. And we see that there's 34% of participants that have participated in a medically supported detox at a hospital and actually completed that process. And we know that engaging in detox can be challenging because there's certain barriers in the way, like wait lists. And for patients, anecdotally speaking, many of them kind of share their experience that having that sort of drive and willingness to participate in detox, it can be a slim window where people are in a space where they can feel ready to participate in detox. And so it's a very daunting process, as the patients have shared with us. And it's something that sometimes when people finally feel ready and safe to participate in detox, there might be barriers in the way, like having to wait a few weeks to get a bed. Next, to talk about bed-based or residential treatment. Oh, sorry, I didn't share the percentages there in the last slide. It was 23% of participants who have participated in those kind of treatments. And finally, when it comes to oral naltrexone, Narcotics Anonymous being very popular in particular, and AA as well as therapy, 58%. So a good chunk of the participants have participated in these kind of treatments as well. And we can go to the next slide. We asked them also about their treatment experiences with concurrent disorders that they're experiencing. So as we spoke on earlier, many of the patient population have been diagnosed with a mental illness and have experienced things like suicidal ideation. But when it comes to receiving treatment for their concurrent disorders, 38% have received medication for mental illness, and 18% have received psychotherapy for their mental illness over the past 6 months. And again, anecdotally, some patients kind of have shared that they struggled with actually getting prescriptions from their physicians, getting the diagnosis they feel comfortable getting. And when it comes to therapy, there are certain barriers that they experience as well. So that kind of speaks on to these rates as well. Wonderful. So this slide kind of highlights the perceived helpfulness of treatment. So we actually asked patients, how helpful have you found these treatments that you've undergone? And the majority of patients have said that they're very helpful or helpful, with 29% saying very helpful and 30% sharing that they have been helpful. But there have been a good chunk of patients who have also said that these treatments are not helpful, or they have felt neutral about that. So it definitely warrants, again, some kind of reevaluation of how we can best support patients who might be dealing with adversity from different lenses. It might not just be their addiction to fentanyl. It could be other concurrent disorders that they're also struggling with, in addition to that accessibility issue that is very, very prominent as well.
So I'm sharing some evidence regarding patient satisfaction and perceived helpfulness of services, which have been long identified as important factors in determining treatment success. And to support this assertion, I'm sharing a 2021 article that reveals an increase in opioid agonist therapy dissatisfaction scores that showed a positive association with exposure to fentanyl. So essentially, what the group did was looked at opioid agonist therapy satisfaction scores, the distribution of patients on these medications, and adherence rates prior to the shift in the drug markets towards a dominant trend of fentanyl. And what they found was satisfaction scores decreased as fentanyl became the dominant opioid. And this was for the majority of patients being treated with methadone, and about 80%, smaller percentage, about 10% on buprenorphine, injectable opioid agonist therapy, about 7% sustained release oral morphine or Cadian, at just under 5%, and 1% otherwise. And I think that reflects well on what Raha had just shared around patient feedback, that about 50% of our patients experience satisfaction with the existing healthcare system, but the remaining percentage expressed either neutrality through the perception that the care that they're receiving is very unhelpful. And I think of all of that, especially through a lens of complex concurrent disorders, which we saw rates of in greater than 70% in our patients, where in addition to medication management for opioid use disorder, given the prevalence rates of mental health, what we're seeing is very few patients are actually accessing evidence-based medication or psychosocial support for their mental health diagnoses, which is also inversely related to engagement in the healthcare system and adherence in treatment over time. The next portion of the survey asked about patient experiences with safe supply. And what was interesting for our group is that safe supply was not ubiquitously accessed by patients. About 50% of patients who did receive safe supply, the dominant was through prescription of hydromorphone. A smaller number of patients, about 10% were on Amezlon, 20% of patients were on the fentanyl patch, and interestingly, about 5% were not aware of safer opioid supply or pharmaceutical alternative management. And patients had a lot to say about the experience of safe supply. I'll actually say patients had a lot to say in response to most of the questions on the survey, which is why some of the responses were on the longer end for what we might have anticipated. And as we talk about our next steps, we'll share what we're hoping to do with that, because there's certainly a huge richness in the responses that we received from patients. But we'll offer a quote from a patient who felt very strongly in a positive way regarding safe supply.
Yeah, so I'm going to go ahead and share this quote that was given to us by a patient. And the patient in this case said, that this is actually the final question of the survey that asks, do you have any ideas or suggestions about what the government should be doing relating to the 2,000 plus deaths from the opioid overdose crisis that we saw in 2022? And this patient shared in response to this, it's a bit of a daunting question, but they shared safe supply. I'm a hardcore advocate of this. Drugs are so cheap to manufacture, especially for Canada, where we source the largest bulk. I look at it this way: the cost to society of keeping the current system versus cost of introducing safe supply. On one hand, even children can buy hardcore drugs, and it's funding organized crime. And these people go and spend it on organized crime. If you want to cut the organized crime, you give them access to safe supply drugs. Stop funding organized crime. Simple. It's not simple. For some of the older people, it's hard to accept that you can give people drugs and they're not bad people. Safe supply saves lives. Do you think people really want to be using drugs? For most people I know, they honestly don't. So many people I know are so abused and come from such troubled backgrounds, and they just want to feel some type of relief. It's a real problem to try and think that you can solve these people's issues in just 1 or 2 steps of therapy. So yeah, I think this quote really captures nicely a lot of people's sentiments regarding their frustration with lack of access to things like safe supply. And we definitely come a long way in providing these for folks. But again, this quote also encapsulates some of the stigma associated with engaging with safe supply and kind of the polarity that many people experience and the perceived state of stigma as someone who uses drugs as well. And how so many people that are in the state of using fentanyl come from troubled backgrounds, as this person said, and they have experienced neglect and trauma. And it's really important to take on a holistic approach in caring for them and showing them care that's loving and tailored to their needs. Yeah. So this finding is on the topic of overdose. So in our survey, we ask pretty in depth on people's experiences with overdose. And the percentage of participants in our study that have overdosed is 82%. And the mean number of overdoses, the average overdoses, is 14.6, with the median being 5. And the standard deviation and interquartile range for this for these data is quite large. And that's because there is such a large range of reported incidences of overdose. Some people have experienced no overdoses, and some people have experienced just a few, maybe 1 or 2, whereas other people on the extreme end have reported experiencing close to 100 overdoses. And this is really worthwhile into investigating. And our research team is actually currently doing a cluster analysis on these findings and trying to identify patterns for these clusters of extreme groups and correlate these with their patterns and risk awareness. So we're trying to figure out if people who have experienced maybe 50 plus overdoses, what their perceived risk awareness is and what their practices are, and what this looks like for people who have only experienced a few who have never overdosed before. So yeah, this is definitely a staggering number.
So as Rahul mentioned, the majority of patients have an overdose history from our respondents, and many of our patients have experienced recurrent overdose from the toxic unregulated drug supply. A follow-up question about the experience of overdose was whether individuals would choose to go to a hospital in the context of an opioid overdose, and why or why not. And I think these statistics are really somber. Only about 43% of patients indicated in the affirmative that they would seek medical care after an overdose. And the remaining 65% of patients, or 67% of patients, said no, it depends, or were unsure, or preferred not to answer. And as Braha said, we're in the process of analyzing the data now to look at those overdose clusters, to pair the associations of risk and protective factors. But this slide to me really showcases, I think, the value of the survey and hearing from patients about their experience of the healthcare system. And as I've already alluded to, there's been such a richness in the responses that we've received from patients. But in this particular time, there were several themes that arose around why individuals would prefer to avoid the emergency department or hospital level visit. And that came around a burden of time, a perceived lack of recognition and appropriate management of withdrawal states, the response from patients that they have the ability to more effectively self-medicate in the community, and more trust with providers in safe consumption sites or overdose prevention sites. And a really major theme that arose was the experience of stigma and discrimination in healthcare settings. So some quotes that patients said was, what's the point in going to the hospital? It's a waste of resources. I don't like being here. I feel like I'm wasting resources. Another patient said going to a hospital just wastes time. And another individual responded, no, I wouldn't go to the hospital because they're rude to junkies. So these are the experiences that our patients are entering the hospital system with, and they're carrying that across their treatment continuum. And I think it really underserves the importance of the work that we're doing and how we administer care. Lastly, in the survey, we finish up with a series of questions about adoption of harm reduction behaviors, and there's many that we asked about. We're sharing this sample of responses that many patients are engaging in harm reduction behaviors. I'll be very interested to see in the overdose cluster analysis whether adoption of these harm reduction behaviors is associated with the lower prevalence of recurrent overdoses. About 72% of patients are carrying take-home naloxone. 40% of patients are using other harm reduction supplies. So that might mean they're receiving supplies for safe injection or for safe smoking to avoid sharing or reusing supplies. 20% of patients are getting their substances checked using test strips, and a slightly smaller percentage are actually doing that through a facility that has a spectrometer. About 40% of patients are using supervised consumption sites, and 60% are using with friends. From a quick analysis of this data, I think what this shows is that with more effort and advanced planning required for engagement in some of these services, we see lower rates of adoption. So, needing to go to a supervised consumption site or getting your substance checked at a specific facility, figuring out whether there's actually approval to use via smoking as opposed to injection. These are major considerations for the facilities and how patients are actually able to access them and utilize them as they can. So we're moving in to sort of wrap up and provide a summary of the current study. To the aims, as a reminder of the BC fentanyl cohort study, were to gain insights into the motivations behind fentanyl use and the impact on physical and mental health, really in an effort to move away from the impressionistic belief that patients are self-selecting for fentanyl, though we're learning that many are. Another aim was to evaluate the effectiveness of interventions such as opioid agonist treatment, mental health support in real-world settings. And our data really reinforces this consistent cycle of engagement and disengagement from opioid agonist therapy, limited access, especially to on-demand mental health and substance use services, with low rates of retention and completion and detoxification and bed-based treatment, and a lack of concurrent disorders management. Another aim was to identify barriers to the uptake of these evidence-based practices, and the intention will be to use this information to develop strategies to overcome them. That is still an ongoing component of the survey. And finally, trying to inform policy decisions as they relate to harm reduction, access to treatment, and especially stigma reduction, and to expand education across the healthcare system in especially emergency departments and hospitals where many of our patients may receive care. And the next steps that we see supporting these goals are to continue with recruitment and site expansion. We've alluded to some of the ongoing data analysis that's happening, such as assessing overdose clusters and to better understand the risk and protective measures that folks are engaging in. We're planning to expand the survey to do qualitative narrative assessments with patients. As I said, the patients surveyed they were treasure troves of information, and many had very actionable beliefs as service utilizers. And I think additionally, a piece that we heard from individuals was that as utilizers of the system of care, they should be included in decision-making and policy decisions that affect them. So being able to have a voice and to hold that position of advocacy. And so in our last couple of slides, I'm just going to share some additional details detailed responses from patients about what we as the healthcare system and the government should be doing to curb the deaths from opioid overdose crisis. And one patient shared that quicker access to detox and treatment would be really important, that the wait times are preventing people from getting the care they need. And every day is a life or death situation. And if patients can't get it right when they need it, they could be going out the same day and overdosing. Another provides the perspective that more services related to mental health and substance use, and especially the social determinants of health, are needed to be better supports for patients, and says they're doing everything wrong. It has to happen in the community, socially, with people not just disbanding people for being in that lifestyle, because that's just pushing them away. To heal, they have to feel loved and cared for and wanted, and they're doing the exact opposite. There needs to be systems put in place to help people in their homes, to take care of them physically, like food and healing. So really thinking about foundational individual needs. So that brings us to the final slide in the presentation. We'll open up for a question and answer period, which we've got about 15 minutes to do. And, as we're transitioning from very much a research questionnaire and patient survey, really thinking about how we're going to translate that into action. And we're hoping and aiming to through the process of knowledge translation, develop evidence-based interventions, expand the integration of services for mental health and substance use, equip healthcare providers with the knowledge and skills to develop effective care, and really to reduce stigma. And that's going to require a lot of training and education. And lastly, being able to impact the policy change and advocacy perspective to advocate for policies that promote harm reduction, treatment access, and support for individuals with substance use disorders. And with that, we will pause. And Vivian had to drop off as she had clinical care that she needed to get to, but Raha and I are available to answer questions.